Hi, this is Sarah, and this is my MSK Lumbar Pathology virtual practical. So after reviewing the case, the working diagnoses that I have include spinal stenosis. I came to this conclusion due to the nature of the patient's occupation of the cable installer, as well as the aggravating factors including walking, standing, and bending over. Another pathology that I came up with was a facet joint pathology. I came up with this due to the patient's apprehension to manipulation on the spine, as well as their the pattern of pain being consistent with that of referred pain from the joint. So that pain being greater trochanter, posterior lateral thigh, the buttocks, and down to behind and below the knee. My last diagnosis that I come up with is a posterior lateral disc pathology with secondary nerve involvement. I came up with that diagnosis due to the patient's positive single leg raise test, as well as the slump test, and the deviation that they have to the right, which would be opposite of the pain that they're experiencing, which would be suggesting of a shoulder lesion on the spinal cord. So a red flag that I came up with was the night pain, that the patient has to take a lot of medication in order to sleep at night. My problems include the pain rating of 5 in their left leg, and that can rise up to 7 or 8 out of 10, and the significant impact of the pain on their ability to perform their work and their ADLs. So we're going to do a quick neuro screen. I'm going to have the patient look away, and she's going to tell me when she feels me touching her.
Yes. 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 Yes.
All right. And then I would start on the uninvolved side and then repeat it on the involved side. Next, we're going to assess gross range of motion. So I'm going to ask the patient to try to touch their toes. So go ahead and go forward. And I would ask if that causes any pain.
Yes.
Okay, and then stand back up. And then we can do extension. So bend back. Does that cause pain?
Yes.
Okay. And then we'll do lateral side bending. So run your finger down the side of your leg. Good. And then come back. And then do it on the other side. Good. Did that cause pain?
Yes.
All right. She's very aggravated. Next, we're going to do a special test. We're going to do the Wells leg raise test. So if you can lay down. And this should be on a firm but comfortable surface, and keeping her neck neutral. I'm going to grab the unaffected side and support the heel in my hand, keeping the foot in neutral dorsiflexion and maintaining extension of the knee. Now I'm going to rise it until the patient reports pain in the involved leg.
Yes.
All right. And this is a positive test if the pain that they feel in their involved leg is the concordant pain. So I'm going to follow the traction-based treatment. I am using this treatment due to the patient's possibility of stenosis, as well as their nerve involvement, their distal presentation of symptoms that are not centralizing. So I'm going to do this by performing traction, so you can lay down. And the patient's going to have her knees bent and remain on the surface of the bed. I'm going to grab behind her knees and apply traction with my body weight. I'm going to hold this position for a minute or two, making sure that it does not increase pain for the patient. Does this reduce your pain?
Yes.
Good. So I will hold this position for, I would hold that position for a minute. If I can manage to hold on for 2, I would do that. And then ask the patient to perform exercises while I'm taking a break, so that way the reduction of pain will allow them to perform the exercises more comfortably and move more efficiently. So I continue that cycle 2 or 3 times to fill out the 8-minute treatment time. So one of the home exercise programs that I will teach the patient is with a medicine ball. She's going to contract her abs, dig in with her heels, and then move the ball forward. And it's important for traction-based treatment to obviously perform traction, but also to influence flexion exercises. All right, and you can sit up. So the prognosis of this patient would be fair due to the fact that I can mechanically influence their pain and their symptoms. And if the traction is able to help centralize that pain, I could use that to have an impact on their impingement and would expect resolve of symptoms in a time span of 4 to 6 weeks. So a long-term goal that I would have for this patient is that the patient reports a functional scale improved to 100% with ability to complete all tasks of work and ADLs in order to return to prior level of function.